Hello. So this is part 3. We're not rushing through the day. Sorry. No, it's okay. And it's a pleasure to be the first session after lunch because I know everyone's satiated and ready for more learning. So I am Lola Adedokin. I'm the director of the Child Wellbeing Program and the African Health Initiative at the Doris Duke Charitable Foundation. It's a mouthful. The foundation has been around since 1997, and we fund in 4 areas to serve a mission of improving people's quality of life. That means we fund in areas related to arts and culture, environment and climate change, child well-being, as well as medical research. So there are so many themes that have come out through the day that really do reflect our passions and interests. I do want to talk a little bit about our child wellbeing program and what we fund, how we fund. Our mission is pretty broad. It's to prevent child abuse and neglect and promote child wellbeing. So that's everything. The way that we have tackled that grant-making strategy is to invest in 3 core goal areas. The first being place-based approaches or neighborhood-level approaches, which we've heard a lot about today. Within that lens, we think a lot about investing in multi-generational approaches that focus on children and families as the center. We also focus on taking a prevention lens to all the work that we support, and also thinking about how data, evidence, and research is really used in a practical way to inform decision-making within policy, and as well as the implementation of high-quality services. So we're really keen on really accelerating and connecting that no-do gap. The second area that we support is facilitating cross-sector or cross-systems collaboration. Again, another theme that's come up throughout the day. So that for us takes different forms. We really want to inspire and catalyze partnerships across sectors, including child welfare, health, housing, transportation, all the sectors that really influence outcomes for children and families in disadvantaged communities. And the third area, which has seen some refinements in the last 2 or 3 years, is around not only supporting filling in the gaps in research for populations that are often ignored. For that, particularly speaks to children of color, but specifically Native American and Alaska Native children, indigenous populations that often go underserved and understudied. We also are keen to ensure that what we learn is distributed, documented in a way that can be used outside of academia. It's been a pleasure to hear a lot of academics come and present today, but for those who want answers and want to fund solutions, we need accessible information that we can make activate and act on. And within that area, we've just recently begun to think about leadership. So we talked a lot about the systems at play that influence outcomes for children. What I haven't heard much of, but is certainly at the heart of all of your work, is who are the people who can lead complex interventions? What characteristics do they need? What support do they need? What training do they need? So we're hoping to now, we've actually launched, we're supporting a series of fellowships to address that skills need or skills gap. And we're also working on supporting leaders who reflect the populations that they serve. I don't know, there was a recent report that came out earlier this year that shared that actually 7% of nonprofits are led by people of color, when in fact those that they're serving are people of color. So we need to figure out how to ensure that those who are being served by people who truly know and can connect with those communities. So I'll sort of end there, but I just want to also note that we've talked a lot about the science, but this work is really also an art. So if we can understand the art of delivering complex services alongside how we use and draw on and generate new data and evidence, I think that really is going to help to catalyze and accelerate changes in underserved communities. So I've had the pleasure of reading the papers and chapters by my esteemed colleagues, and they have a series of case studies that are really quite interesting. The panel is also interesting because it reflects international experiences, US-based experiences, and provides an opportunity to share key lessons learned. Often the lessons learned setup is that the US shares lessons with others, when in fact there's so much to be learned from other communities and societies. So I hope we can find that balance in our discussion. So with that said, I'd like to call my first panelist, Brian Castrucci, to the... Thank you.
Good afternoon, everybody. There's some energy for you. I could probably ask the people on the interwebs, and I'd hear them better than y'all. Yeah, like yell out on the interwebs, and we'll just hear them. So good afternoon, everybody. Okay, better. So I'm Brian Castrucci. I am the Chief Executive Officer at the Beaumont Foundation. Of course, thanks to the whole front row here for having us do this chapter. And one of my co-authors is here, David Jernigan, who's also a BU professor. The foundation is dedicated to improving the people, the partnerships, and the policies necessary to achieve optimal health in this country. So when I think about health, I kind of think about this, okay? When you really think about how we take on health in this country, we often talk about our zip code means more to our health than our genetic code. And we know that's true. The literature says it really clearly. I mean, clearly if you live in an impoverished neighborhood with poor schools, you have different and maybe worse opportunities than someone who lives in an affluent neighborhood with great schools. But typically, our solution is just bigger and more buckets. And even now, as we're starting to see healthcare move kind of forward and take on what they're calling social determinants, which is really social needs. Patient comes into the hospital, they need a place to stay that night. It's cheaper to let them stay at give them a housing voucher for the evening than put them in the hospital. That's still very much an individual focus. It's a different kind of bucket, but it's still a bucket, right? What we really know is that the policies, rather than pills, are the real prescription for better health in this country, right? So all those things at the bottom, ACA, traditional healthcare, value-based contracting, social needs intervention, all of it is just ways to kind of deal with disease after it happens. But what actually shuts off the spigot? And that's our question at the Beaumont. What shuts off the spigot? And this is not to be kind of anti-medicine. I think we have an extraordinary healthcare system in this country. The problem is with that shift to chronic disease, what healthcare can do for us now is different than what it used to be able to do for us. They can't cure us. And often where we're living confounds even the treatments that we have for most chronic diseases. And so it was with this in mind that we started to think through how do we give cities a package of evidence-based policies and solutions that could help millions of people live longer, better lives in vibrant and prosperous communities. So CityHealth really aims to identify those policies that improve people's everyday lives. So this was originally created by the Beaumont Foundation, but in probably one of the more exciting developments for us at the foundation, Kaiser Permanente joined us this past spring. And that's the business, not the foundation. And so the fact that Kaiser, viewing the need for policy as a healthcare, as the largest integrated health system in the country, decided to put money into CityHealth was really important, and I think shows an important sea change about how we deal with disease and how we achieve health in this country. So when we think about why we actually chose to work in cities, we view cities as the real place where innovative solutions are born, tested, and proven. City officials are really at the forefront of some of the biggest challenges in this country, and they're skilled at adopting new policies even when we have federal and state gridlock. So we took on this task of trying to create an evidence-based policy package, which is maybe harder than it sounds, but to really get to where we wanted to be, we started with social determinants of health. And we said we at least wanted something in each of these areas. And we thought that was really important for us to be able to have a broad swath of policies. We then looked at these criteria: evidence-based return on investment, impact on city revenue, potential impact health disparities, potential political feasibility, and ease of implementation. Now, all of those can be summarized in kind of one word: practical. Okay, we all know the policies that we want to see. We all know the policies that we should have. these are the policies that we can have. These are the policies that wouldn't contribute to more gridlock, but actually would contribute to forward motion. So it was with this kind of idea, we did a literature review, we did a municipal policy review, we checked out the policies, we identified a set of policies, we brought a blue ribbon panel together, we vetted them, and the blue ribbon panel were political leaders, both blue and red, large retail chain stores, membership organizations, a whole swath of folks to say, okay, what really makes sense? And their task was to help us really identify the right mix of policies that would inspire leaders to take action. And so the outcome of the process was this 9-policy package. And so here are our policies. Now, everything I'm talking about is on www.cityhealth.org. But note, this is not necessarily the policies you'd think that would necessarily come from a health foundation, right? Paid sick leave, not necessarily traditionally in the public health bailiwick, but clearly a policy that supports health. So once we had these policies, we actually, and this is the really cool part of the website, each of these policies has the clear metrics of how we then ranked whether you had them. So this is one example from procurement. And what you'll see for each of our policies is what it takes to be bronze, and we consider bronze to be passable, silver, which is good, and gold, which is best. So each of these policies is rated on this gold, silver, and bronze metric. And then across the 9 policies, we did the overall gold, silver, and bronze for the cities. Gold being 5 or more gold medals, silver being 5 or more gold or silver medals, and bronze just being 4 medals of any color. So note, because this is always a thing that people kind of argue with us about, like, oh, why those 9? And what if I can't do all those 9? Well, that's okay, because you don't need all those 9. There has to be some flexibility. And so this was our kind of basic standard of how we graded the cities the first time around. So we took all of this and then did active policy surveillance in the 40 largest cities in the country. We did it in 2017, and then we did it again in 2018 after we worked on this for a year. And that's really one of the important parts about Beaumont. We're not there to tell you that you're not good. We didn't do just ranking and say, like, hey, you suck, good luck. Okay, we said, listen, you're not doing so good, but we're here to help. We put money on the ground. We actually worked with folks. So in 1 year, we got 24 new medals in 1 year. We had, here is all the scores from 2018. You can see if your city is there. We had San Jose join us as a gold city in 2018. Here's the big story. 10 cities increased their policy medals. And we had 6 cities, those who highlighted in yellow, who didn't medal the year before. And this is places like San Antonio that passed Tobacco 21 and paid sick leave. This is Kansas City that's going after early pre-K and did healthy vending. These are real changes that these cities' mayors and health commissioners are leading. We still got a lot of work to do. We got 15 cities that don't have an overall medal. And what's really important, and I can't let this whole symposium go by without saying the word preemption, because ceiling preemption is hurting these cities. That is probably one of the greatest threats to urban health that we're seeing, is states coming in with ceiling preemption and taking away the authority of the cities to do what they do best, which is protect their people. Just a quick look at where our policies fall out. We have 3 policies that have high penetration, still working on the others. This gives you a sense of the medal distribution. Again, all of this is on our website. We encourage you to go talk about these policies. While we rated the 40 largest cities in the country, that was a resource limitation. These policies actually work for Malden as much as they work for New York City. And so what's next for City Health is we are actually working on our next policy package. That's what David is heading up for us, adding new policies like menthol, or eliminating menthol, or paid family leave. And so we want to keep moving the bar because, again, the only way we're getting healthy is through policy. It's the best prescription for better health in this country. And while we talk a lot about pills and procedures, it's policies and partnerships that will deliver better health. And with that, thank you.
Hi there. I'm Karen Lee. I'm just waiting for my slides. Oh, I have to press the green button? Okay. This green button? Sorry. Nothing's happening. Okay. Do we have tech? Okay. All right. Maybe I'll just start by introducing myself. So I'm Karen Lee. I'm now back in Canada after about a decade and a half in the US. I first came down here to work for the US Centers for Disease Control and Prevention, and down in Atlanta doing built environments and policy work around obesity and chronic disease prevention, particularly around physical activity, and then was recruited up to Mayor Bloomberg's administration in the CityHealth department to work on these issues, and I worked there for about 9 years. So I'm actually going to share a case example and case study of New York City. So, okay, I guess I'll just start with no slides. I've got some notes here. So I think if we look at our public health issues of the day, right? Public health really began in the 1800s in many of our cities. Dealing with infectious disease epidemics, right? So issues like cholera there were multiple epidemics of them in many of our cities. Issues like yellow fever that were transmitted by vectors like mosquitoes from standing water that were found previously before they were eliminated. Diseases like tuberculosis were endemic. The conditions in which we live in our communities really drove the types of diseases that you would see, right? So in many of our cities, particularly in our poorest neighborhoods, housing there was severe overcrowding. Buildings didn't have windows necessarily because they weren't required, right? There were not yet building codes, as an example. Zoning didn't exist, and so, buildings would haphazardly come up, and there were no requirements for things like setbacks that would require buildings to be a certain distance apart so that light and air could enter our streets. So mosquitoes bred in those standing water puddles. Clearly issues like maternal and infant mortality were important. Because a lot of our codes didn't exist, safety was also a major issue, right? But infectious disease is a leading cause of mortality in our 1800s and early 1900s. And today, we've got a very different set of conditions, right? We've got chronic diseases and risk conditions like obesity that are rising globally. Aging populations, as we've heard earlier. Mental health issues are a major source now of morbidity. Oh, here we go. Of morbidity, even though they may not be the highest causes of mortality. Climate change and environmental pollution, really important. And going back to history, right, one of the major ways, of course, that we mitigated some of our previous epidemics was to actually address the environmental conditions in which these epidemics flourished, right? So we've talked a little bit about the issues in the past. And our successes in infectious disease mortality actually occurred before many of the medical technologies that are available today became available. So here's a slide from New York City showing that, in 1880, about 60% of deaths due to infectious diseases. By 1940, prior to the widespread use of antibiotics, penicillin, the first antibiotic, not discovered until 1939, antibiotics not in widespread use in 1940, and yet major gains had been made, right, in infectious disease mortality, in part because of all of these environmental undertakings in cities like New York and other cities, right? So infrastructure for sanitation, for clean water, for even like public parks, and the creation of transportation systems like the subway was in part developed to address the severe overcrowding in certain areas of the city, right? And so resulting in improvements, major improvements in issues like infectious disease mortality, even before the advent of a mainstay of treatment, which was the antibiotics. Today, leading causes of death, we've talked about non-communicable diseases as really important epidemics that we must deal with today. I highlight physical inactivity, unhealthy diets, and some of the conditions that they impact: hypertension, overweight and obesity, high cholesterol, because my talk's going to focus on that. Also, I think if you look at high-income countries, many high-income countries and the cities in them have dealt with issues like smoke-free bylaws, and because of that, we've actually made some important gains in those diseases. So evidence-based interventions include community design. So the Task Force for Community Preventive Services that is actually convened by the U.S. Department of Health and Human Services has actually looked at the literature and systematically reviewed it, and has concluded that there's sufficient evidence now to address community design, both design elements and the policies that can shape that. And when they were looking for this, specifically for physical activity, they found improvements of over 160% in physical activity associated with improvements in community design. But not only that, they also found secondary impacts on increased sense of community, decreased isolation, decreases in crime and stress. Similarly with street design, so when we improve streets for things like walkability, for lighting, for landscape, including better landscaping, for traffic calming, and policies that could shape that, associated outcomes were 35% improvements in physical activity, increased sense of community, and decreased isolation, reductions in crime and stress. So hopefully, this also illustrates that when you actually move upstream in the determinants that you deal with, you can actually impact multiple priority health outcomes all at once. Building design, also important. So simple things like placing signage in front of elevator call buttons outside of stairwells could increase, associated with increases in physical activity through stair use of 50% as a median, right? Also, other emerging studies talking about, if you're in a very high-rise building, you can stop your elevators, right? So they don't stop at every floor, except for the one elevator for disabilities access. Designing stairs to be more visible from building entrances, more pleasant to use are also important. And then, of course, food, we've talked about that earlier. Food retail environments that actually support healthy food access, that's also affordable, as opposed to unhealthy food and beverage exposure. So what can be done if we wanted to address these built environments to improve health? Clearly, we in health do not plan our communities, design them, build our transportation systems and housing and even our worksite buildings, although we have facilities people who might work in our health organizations who do that. And so if we're going to actually impact these parameters, we need to form partnerships, right? And if we're going to form partnerships, a really efficient way to do that is to actually create forums of dialogue that bring together different stakeholders and different cross-sectoral partners and professionals, both from the public sector and the private sector, for conversation. Those conversations will actually create ideas that you can then follow up upon to create initiatives. And really important not to let the excitement of the conference kind of die away without actually having inter-conference initiatives and successes. So creating joint initiatives that can actually arise from your conferences and from the ideas that are actually generated by the other sectors themselves. So for example, the Active Design Guidelines in New York City is now actually, when we track its downloads, is actually being downloaded by architects, planning professionals, urban design professionals, landscape architects, folks who work in the built environment sectors in over 100 countries around the world. And I think we've had success in these guidelines because we created them with and for built environment professionals. So we took the evidence base that was out there and we translated them into guidelines that would actually be usable outside of the health sector. So anyways, it was co-led by 4 city agencies: health, public works, transportation, and planning. And it had actually the inputs of 8 additional public agencies, as well as private sector and community groups and academic groups. We integrated, so another important issue is, so you have your forums for dialogue, you create excitement, then you want to create initiatives for that excitement to spill into and to create successes. Once you actually create resources like guidelines, you need to actually find resources to implement those guidelines, right? And to integrate them into policies themselves. So the active design guidelines, for example, were implemented into all public sector design and construction contracts in New York City, into street designs, building designs, schools, public buildings, affordable housing. And so even as government entities, there's already a lot of power that you can have over infrastructure. And you know, some of these policies require regulations and legislation. Others require an administrative change in the administrative policies that are adopted by these groups. And so it doesn't actually have to necessarily go through a political process if you've got strong partnerships with these other sectors. It was also really important for us to not only enact these policies, but to train the staff across all these various departments that we're going to try and enact these policies. And we also worked with professional associations like the American Institute of Architects, Planning Association, Green Buildings Council, where our built environment professionals were members and resided, and so it was a way for us to reach them. So anyways, needless to say that you know, by integrating these into our various policies and working across groups, for example, with planning and with our environmental sustainability groups, we were able to integrate health directly into our master plans. So a master plan is, you know, a plan usually developed by planning that actually shapes the direction in which a city moves. So that's a very important opportunity. And we went all the way down into, as we were greening the building codes, being invited to the table to have actually a health and physical activity committee. And we were able to integrate actually healthy food, healthy beverage, and physical activity components right into new building codes that were improved as a part of greening. And then, of course, the importance of equitable environments as a way to achieving health equity, in addition to programs that target high-needs populations. Anyways, you know, this work in New York City, not just mine, but teams across New York City's health department really resulted a focus on basically environmental change to support healthy behavior changes for chronic disease prevention, led to measured physical activity in adults in New York that were 3 times higher than the rest of the US. Life expectancy, at least at those, in that period, that was 2.2 years longer and rising faster than the rest of the US. No physical activity in the last 30 days significantly decreased after being flatlined for a decade before that. And then other outcomes like traffic fatalities dropping and childhood obesity reversals that had begun. So thanks very much. If you're interested in this, there are some courses coming up. Thanks for everything.
The green one, okay. Good afternoon, ladies and gentlemen. My name is Waleska Caiaffa, and before I go fast in this presentation, I'd like to thank very much David, Sandro, Catherine, and the team that has been working just to make this being true, because I think that this is a wonderful opportunity. I really appreciate, because I liked very much the other book. I really am a fan of yours in terms of this book. So thank you very much, and thank you for bringing me here. So I'm going this. I'd like also to thank my colleague, Professor Guta Amelia Augusta, who worked with me in this chapter, the 37th chapter. Okay, I'm going to share with you our experience on our Observatory for Urban Health in Belo Horizonte City as an innovative and cross-sectoral collaboration in urban health. Oops. Oh, please. Oh, the green one? Okay. So I will keep my presentation just as I was advised to do in terms of how does this help advance our understanding of health in cities. Well, our observatory, it's a partnership since 2002, so we've been there for 16 years, between the Federal University of Minas Gerais and the Belo Horizonte City Hall. It was created by academics and municipal technicians that were in the CityHealth department. The idea was to find ways of bridging the gap between science and public health policies. And we have a mission, to build workforce capacity in population health research and to conduct urban team studies that can drive planning for improving urban health. So our conceptual model is pretty much related to the health inequalities, to the spatial inequalities, and the social determinants of health. And the idea is to combine forces to provide empirical basis for determining which urban health interventions might work. So this is our core projects. We are using, we always looking at some micro or upstream, international, regional, national, municipal levels policies, trying to look at the local policies in terms of the intervention, how it works for health in terms of the urban, intra-urban effects. We've been working with health sector and outside the health sector policies as well. And we have all those projects going on, but I want to share with you the urban equipment for health promotion and physical activity. So I'm going to tell you a case of a case. So this is Belo Horizonte. Belo Horizonte is a 2.5 million inhabitants city. We have a very fast-aging process, and we also, the city was a planned city, but since the 1950s, this planification was destroyed by everything. So the city has a very interesting leadership in terms of the combination of the master plan and the development of the city in terms of the participatory budgeting as a governance model. Those in the first slide, the right one, we can see the work that has been done through the participatory model. And this case study that I'm going to show you, the Academia da Cidade, it is related to this participatory budgeting process. And as you can see, it started in 2006, the implementation of the fitness center. And you see that growing up very fast. And we, as an academic person, academic group, we are nested at the university. We started a little bit late, as usual, when they decide to implement this. We are always late, but we're trying to figure out how to go do better. So we just organized a very mixed method study. We used only 2 of the sanitary districts of the 9 ones in the city, because we didn't have money enough. But we were able to at least to understand and to capture the heterogeneity of the city using only those 2 district sanitary. So we will elaborate this sampling frame. And the idea was to understand the impact of a fitness center, comparing not the person that were participating of that health promotion activity, but the ones that were living nearby the area. So we, as usual, when we went to the field, there was one already built up. As you can see, that's arrow there. So it's a very comprehensive building process, and we can have 30 minutes of class and 30 minutes of walking. So there's a lot of capacity building and capacity training on that. So we did that. We used several scales involving the social environment, the built environment. We used the systematic social observation. And we were able to do a natural experiment using some analysis related to propensity score adjustment. So those are the papers. I'm not going through them that have been published. And one thing that is very important for us that those papers are from our students, doctoral and master students. So they are all involved in this process, trying to understand and to generate this pieces of this evidence according to our conceptual framework. So you can see physical activity were associated with social context, social cohesion, safety and mobility, in presence of the physical activity, the physical equipment in the neighborhood. We could see that the presence of the academy accounted for 18% of the association between physical activity and the presence of the academia for those living within the 1,500 meters surrounding that equipment. So we have a lot of opportunities and way forward. We are maturing. We are teenagers still. We have several problems, especially because we are nested at the university. So we have to look for financial projects to support this. But we are exchanging, we are expanding, and we are in a collaborative center of the Ministry of Health. We are also a urban health network for Latin America and Caribbean. And the idea is to continue providing meaningful data for local and national policies and decision-making. And, of course, we will continue our mission of the capacity building. Thank you very much.
Good afternoon. I'm Brian Hall from the University of Macau. I'm delighted to be here. I want to thank Sandra Galea, David Vlahov, Catherine Edmond for putting together a beautiful volume on urban health and making this day possible. So I'm going to talk about urbanization in China, which is a very broad topic. So I just curated a few different areas which I think are important and things I've interacted with in my 5.5 years living there. So really, when you think about urbanization in China, you're really talking about migration. You're talking about massive flows of populations from rural areas into urban city centers. And so what we see here is in 1950, about 11% of the population was living in rural areas. In 2018, we see that that number is 60%, and it's estimated to be 80% by 2050. And so when 80% of the Chinese population is living in cities, we're talking about 1 billion people. So that's not inconsequential in terms of thinking about health and populations. So this slide is not a very good indicator of what transportation of bicycles would look like in terms of health promotion. But we see, not to make light of a situation that's quite serious, but pollution is obviously a major issue and a considering factor in China. Cancer is the leading cause of death since 2010. 78% of cancer deaths between 2010 and 2011 is 80,000 people. The majority of cancer-related diagnosis based on cancer surveillance systems are actually conducted in urban environments. So we know that infectious disease from work that we've done, spatial epidemiological studies that we've done in China, we know that migrant populations are particularly vulnerable in terms of infectious disease. And we also know that distance to testing facilities is actually quite important in terms of increasing uptake in HIV testing in China. Most people are actually testing in hospitals, and so the distance between their homes and the hospitals actually makes a big difference in terms of whether or not they know their status. We also know that migrants are at risk for tuberculosis and emerging infectious diseases, especially in the part of China where I live in South China. And there's not a proliferation of urban slums in China, actually, despite the massive amounts of migration into urban centers. But there are villages in the center of the city which are contexts where health is poor. We also know that mental health is a critical concern. A lot of my work actually is focused on mental health, and so mental disorders like depression is a leading burden of disease worldwide, and especially also in China, with about 6% of the population meeting criteria for depression, with one of the best psychiatric epidemiological studies ever done in 2009, and has yet to be replicated. But that study also showed that about 5% of the population that would be diagnosed would not receive the care that they need. So there's a huge treatment gap in terms of mental health in China. We also know that there are cultural syndromes, and across the world, we can't really replicate our Western biomedical concepts of distress without doing some qualitative work and understanding how populations actually view their health, generally speaking, but also their mental health. And so in one study we did, we found that there's a huge prevalence difference between Shenjing Shuairuo, which is the weakness of the nerves concept, and Western depression. We also know that migrants are exposed to natural disasters. I mean, across a migration continuum, you're going to have accumulated adversities, and they bring those adversities and their histories with them into the cities. And so Sichuan province, for example, is one of the largest sending provinces in China, and they bring those adversities with them to the cities, and of course they're vulnerable then for mental health issues. Interpersonal violence or intimate partner violence is also prevalent, about 41% among migrants in cities, based on data we collected. And one key policy-level determinant of health disparities in China that's unique to the Chinese context, of course, is the hukou system, and that is a household registration. So people have either an agricultural or a rural hukou, and if they traverse this rural urban divide and they end up settling in urban centers, they will have limited access to healthcare, housing, and education, along with a host of other social determinants and other issues that are affecting their health. So as populations are migrating, there's also an unfortunate byproduct of this, and that is the left behind elders or left behind children. And so this is nicely illustrated poignantly by this photographer who actually took pictures in villages and showed for every empty seat here in this picture is a person in the family that has migrated. And so when we see this occurring at a massive scale, we see there's a breakdown in family care systems. And when we see a growing aging population, in rural areas, and also urbanization in rural areas, we see there's a difficulty in terms of meeting caregiving demands for elders and also for children, which will have generational effects. So this is the part of China I live. I live in Macau. So the Hong Kong, Macau, Guangdong Greater Bay Area is an emerging agglomeration of 65 million people across 11 cities in South China. And as these cities become hyper-connected, we have a bridge that was just built recently that connects Macau and Hong Kong and also into the mainland of China. When you see this kind of massive clustering of people in urban centers that are hyper-connected, you also have an issue in terms of emerging infectious disease, which we saw outbreaks of, like SARS, for example, H7N9, H1N1. So in Macau, it's known as a gambling center of the world. It's also one of the most populous places, most densely populated places on Earth. We have about 55,000 people per square mile. So in a context like this, it's interesting to study urbanicity and how that might be affecting population health. And one of the things we looked at recently is we did the first epidemiological study of depression, both in the general population and again among elders, to see if this was an issue that was prevalent and something we should intervene upon in the city. We found that 8% of the population was depressed, and some of the key correlates of depression among elders and in the general population was social capital. So an erosion of trust and cohesion and feeling a sense of belongingness increased the odds of depression. We know that coastal cities are also at increased risk for exposure to natural disaster, which has also been discussed. And so in Macau, we felt this firsthand. Last year, we were exposed to a typhoon that ended up taking the lives of 10 people, 200 injured, and $1.4 billion worth of worth of losses. We did a study of post-traumatic stress disorder 1 month after the event, and then we followed a year later and did a household survey to see what the impact of this event was on communities. We saw that 7% of the adult Macau population would likely have post-traumatic stress disorder, even 1 year later, and urbanicity was associated with this finding. Another byproduct of urbanization in China is, again, this issue of care structures. And so there are populations of migrant domestic workers from the Philippines and Indonesia who are going into Hong Kong and Macau, about 400,000 people, and will soon be going into mainland China as well, so to provide care for children and for elders. We've done a large-scale project with the community, engaging them over some years to understand what their health needs are. So we did a respondent-driven sampling study. We collected over 2,000 sample, and we tried to quantify their disease burden. And what we saw is that depression was actually quite prevalent, 38% of the population. This is based on validated cut scores of common mental disorder instruments. And then we look at urbanicity, we look at built environment and other factors and how that might be associated with their health and well-being. And what we see is that the distance between their homes and casinos in Macau is actually associated with an increased risk of having gambling disorder. We know that green space is also associated with their health. And interestingly, in this population, we see that social capital and social support don't function in the same way as we would think they would function in terms of having a protective effect. In a population that's migrating with a lack of control and who's experiencing discrimination and widespread inequalities, generally we see that increased social support and social contact in their networks is also associated with increased burden of mental ill health. So with that, I want to say thank you, and also thank my partner and longtime collaborator, Chen Wan at Sun Yat-sen School of Public Health. Thank you.
The whole day I've been looking forward to this infamous green button. And it goes back. I do also want to thank the people who put together this book and everybody else who's in this book, because it really is a tremendously wonderful group of people doing very great things. I also realized that no one really has welcomed you all to Boston. We certainly welcome us to BU, but welcome to Boston. I'm a newcomer to the city. I've only lived here 39 years, which I'm a California, and one of the good or bad things about Bostonians is that if you're not born here and your grandparents weren't born here and fought with somebody here, you're never really a Bostonian. But somehow, in those 39 years, I have managed to ingratiate myself in the city, so thank you so much. What you don't realize is what a historical area you're sitting in today, and my case study is really how the history of Boston has shaped people's reactions to health crises and health issues. So in this particular area, within a few blocks of this building, over time, Coretta Scott and Martin Luther King Jr., both before they got married and once they were married, lived nearby. Malcolm X lived nearby, Louisa May Alcott, Alexander Graham Bell, and Louis Mayer of Metro-Goldwyn-Mayer fame. So this is very much a historic area. And I am going to be focused on Boston history, but I think it's important to know that every place, every area, every city, every neighborhood has its own history. And I can tell you this because I've made all the mistakes that people could make. We talk about community-based participatory research. When I was 22 and freshly scrubbed, I was getting a master's in city planning. I arrived as a community organizer in a housing project just a few blocks from here, and I thought I knew everything, right? And of course, I didn't know a thing. But I didn't know the history, I didn't know the people, and there I was telling them all what to do. This probably tells you more. There's an old joke. You can tell a Harvard man, you just can't tell him much. And so that was me. And what you realize is that you just can't plop down into a community and start expecting people to respond to you expecting people to respect you, expecting people to listen to you. And matter of fact, it's quite the opposite. I think several of the presenters today have talked about the importance of long-term collaboration. And part of what happens in a long-term collaboration is that you begin to learn about a neighborhood. You begin to learn about a city and understand how it came to the point where that particular issue that you've been hired or you set your squeaky clean graduate students in to do an intervention, how that came about. In my paper for this book, I actually focus on 3 different types of issues and how they affect current problems, one of which is urban renewal. In this particular neighborhood, for example, 16,000 people were displaced in the 60s and the 70s because of urban renewal and a first round of gentrification. I also talk about public health infrastructure. Also in this neighborhood, a block away is Washington Street, and I'm sorry for this being so US-centric, but for those of you who know Longfellow's poem, The Midnight Ride of Paul Revere, the one to buy land was Washington Street. Turns out the British actually went by sea, but anyway, they would have gone through there. So right there. Paul Revere was also one of the co-founders of the Boston, what eventually became Health and Hospitals, the Boston Public Health Commission. So Paul Revere had a very strong impact on public health infrastructure. And in my chapter, I talk about how that tradition of working with communities, whether it be through community health centers or outreach to folks, really made a difference in Boston during the AIDS years, where unlike other cities where there was a tremendous fight between people with AIDS, communities affected by AIDS, and city administrations, like in New York or San Francisco or Los Angeles, here there was much more cooperation because there was a history of cooperating. It didn't mean that there wasn't rage and anger and tremendous tragedy, but there was, at least it wasn't directed against a city government that was unresponsive. But what I really wanted to talk to you today is about the impact of global climate change on the city. I'm not sure how well, I guess this shows up fairly well, right? This is the original land area of Boston. Basically, we're on solid land here, sort of, kind of. It was actually mud flats in the mid-19th century. After a cholera epidemic, somebody gave the city $5,000 to start up a city hospital. This was mud flats owned by the city that was unbuildable, so they built the hospital here. And to this day, it is the Boston Medical Center. But what you see is several square miles of filled land. As a matter of fact, if you go out and look out that particular window, and I encourage you all, before you leave today, to look out that window. It's a beautiful view. Actually, all the windows are nice. But basically, if you look out that window, all those buildings you see will be destroyed with a 2-meter rise in ocean levels. I mean, obviously, they won't go over the tops of the high-rises and whatnot, but they will go and destroy the first floors. All it will take is a very nice, high tide, and soon we'll start seeing problems. This whole neighborhood is kept out of underwater. Actually, both this neighborhood and Back Bay are kept out from being underwater by one pumping station, which is just a few blocks up the street. If that fails, in any rainstorm, we could be underwater. So without knowing this, you wouldn't understand this. This is, all these colored areas are the areas in Boston that are at risk for a rise in sea level. And what you can't see by looking at a map or just looking out the window is that the streets, when they filled in this land around both sides of what was called Boston Neck, they filled the streets up so they were 6 to 8 feet above low tide, but they allowed developers to fill the backyards up to only 2 to 4 feet above the low tide. So actually, you can't tell by walking down the street in South End or Back Bay, but the street level is one way, and then you look down, and you go down, there's a basement that's now occupied because land is so expensive and housing is so expensive. They've been turned into million-dollar condos, but are basically at sea level. So again, anything were to happen, this neighborhood and the other neighborhoods, somewhere around 6 to 8 square miles of the city of Boston, land worth billions and billions of dollars will disappear. The only way to know that, the only way to understand that is by understanding the city's history. And that's why it's so important that you have to know what is going on locally, know what you're getting into when you go someplace. Now, you might think that that has caused a great deal of consternation and wonderful action in the city. This is actually a picture of the industrial canal in New Orleans, which failed and took out the Ninth Ward. A lesson, not from Boston, from other places, should be that you don't introduce canals into cities when they're at risk for flooding. So when news first came out, when awareness first came out that there was a problem with the city of Boston being overwhelmed, the Boston Society of Architects decided to hold a competition. Let's have all the architects and other people come together, and maybe we could come up with some creative way of dealing with global climate change. So this was the winning design: build a canal down one of the streets. So you wanted to say to these folks, take it seriously. Well, you wanted to. Those of us who are involved in this kind of thing, you wanted to shake them, right? Go, you don't want to introduce water in here. But this is what you get if you don't pay attention to what's going on in your history. This is just one piece, right? Again, when I was this very naive community organizer, I'm probably a very naive older community organizer at this point. But when you go into a place, you have to understand what's going on. You have to be able to engage people. This particular housing development was actually created by Puerto Rican tenants who were going to be displaced by the city. I'm Mexican, right? So if I walk in there, first of all, I start criticizing their Spanish, because Mexican Spanish, for those of you who are Latino or Latinx, I don't know if anybody is here, Mexican Spanish is the most beautiful Spanish in the world. I say that objectively. Puerto Rican Spanish is actually, I don't know, it's very nice, but it's not as beautiful. So somebody would say something, I go, no, you don't say it that way, you say it this. I made every mistake in the world. But fortunately, there were people who were very intelligent and very forgiving and very kind, and they taught me how to listen to a community, how to speak their language, and understand that this was a community that had challenged the city. Puerto Rican people then and as now are one of the most marginalized folks in the United States. They rarely have any voice, and yet they stopped the city from taking their land, taking their homes, and built new homes. So you got to know the history, and thank you.
Okay.
All right, we can bring all the speakers up.
Yes.
I think we have time for maybe one or two questions, please.
Are there questions as folks take a seat? Great. I'm going to take moderator privilege. Go ahead.
I have a question. It went by fairly quickly. In terms of evidence-based policy interventions that make a difference, one I saw out of the corner of my eye was affordable housing. Could you comment on the evidence base for our, you also emphasize the importance of being pragmatic. And from my understanding, the goal of developing more affordable housing is not particularly pragmatic in this environment.
Yeah, I mean, we have to start somewhere. We started with inclusionary zoning. That's one area that we'll expand as we go forward in CityHealth. I think things like rental inspection and other, again, pragmatic solutions. And this is the hardest part in public health, is if you ever take a step back and look at the elephant, you walk away, right? Because it's just like too big and you're like, I'm out. But what we need to do is say, okay, inclusionary zoning is a step, right? The next step is hopefully rental inspection, which was one of my policies that I love, but I got voted down, and I'm the CEO of the organization that funds the thing. So we're trying to make sure that we have a good evidence base, and inclusionary zoning did have enough evidence. Now understand, our evidence bar is not like CDC's evidence bar. It's a little lower, but at least we know it has been shown to work in at least some studies to increase the availability of some housing. But housing's one of the toughest ones we have.
Yeah, may I add that if you look at the Guide to Community Preventive Services, there is actually sufficient evidence that affordable housing policies and affordable housing supports are a health-promoting, disease-preventing measure. So if you look at the evidence reviews that have been done, they include affordable housing policies and supports. I also wanted to add that I think, when we think about affordable housing, it's not just having affordable housing, but designing them so that they are healthier, right? If you look at market rate housing, they increase access very frequently to things like active recreation for adults and children, et cetera. And yet, when our affordable housing designs and policies don't keep up with that, we can actually increase disparities in access. And so it's really important not just to have affordable housing, but how they're designed as well.
I don't have any question about the need or about the potential benefit. What I have a question about is whether it's pragmatic that there will be more affordable housing in the next 5 years, the next 10 years, the next 25 years. I was at an RPA General Assembly with 1,000 people, many of whom are builders, and they were asked whether there will be more affordable housing in the next 25 years. 95% of them said no. So it's a whole issue of, is it pragmatic in terms of implementation?
The pragmatism is inclusionary zoning is something we can pass. If we're not thoughtful about this, Google Austin, Texas's challenge when it developed teachers out of the schools. All of a sudden they're like, oh look, all the teachers have gone to Leander, where you can buy a ranch for $50. But Austin, because of unfettered development, now is unaffordable. So the pragmatism is that inclusionary zoning is something that we can work with city councils on and get them to pass. It's step one. And I think that's the hardest part, is this is a long-term play.
Can I take just one other question? I see a hand there.
Obviously, I agree, know your history, but I'm wondering why not your geography? And what surprises me in the course of the day, we've not heard very much about the sort of spatial relationships at the level of the street in detail. And what surprised me was that OpenStreetMap offers a fantastic resource for the generation of data from the community. For example, the city I'm in, you can see where all the kids' playgrounds are. They're on the map. We know where the defibrillators are. They're on the map. There's that kind of sourcing of data and the openness and transmission of that data, which far exceeds what we've got for Google, which is rubbish anyway, and miles, I mean 20, 30 yards errors often in Google's maps, even if they go beyond the general street level. So why not sourcing data of all sorts from communities and putting it in open bank, as it were, in OpenStreetMap? It seems very straightforward to me.
Thank you for that. I think we are getting ushered off the stage, but I want to thank my colleagues, and we anticipate the book and more conversation. So thank you all.
All right, very good. So one of the, we have had the privilege of hosting a number of symposia over the years, and one of the secrets of hosting a great symposium is to reserve the best panel for last. And that's exactly what we're doing today.